here as part of our LHN and part of the wider health community in our region. Public health was defined in 1988 as the art and science of preventing disease, prolonging life, and promoting health through the organised actions of society. So that sort of threefold aim is very clearly not just the responsibility of the health sector, but it is the responsibility of the whole of society. And therein lies one of the difficulties of public health, because it is very easy to say it's somebody else's responsibility. Clearly, the WHO's view and our Australian government view is that public health, whilst being led by the health sector, is actually the responsibility of all of us. It has big implications for many, both government and non-government sectors. And we only have to see that played out in the public health response to the recent coronavirus pandemic across our country, which has involved every sector of society. The Riverland Mallee Coorong Local Health Network is committed to seeing itself as being part of a public health response for our region, promoting health, preventing disease, and prolonging life. Doing our bit as an LHN, but working collaboratively with all sectors of society to ensure that those outcomes occur for the residents in our regions. And because of that, the LHN has formed a public health unit. The initial members of that public health unit are trained in public health, and you will meet them over the next few months as we work together through this seminar series. But interest and membership in this seminar series is open to anybody who has an interest in preventing illness, in promoting health and prolonging life in our region, and learning more about public health responses. We are very fortunate today to have the convener of our public health seminar series presenting our first seminar. And Dr Felix Ogbo is a general practice trainee in Barmera. He is the other person you can see on the screen. He's looking a little bit tired because he's just been seeing patients all morning, and we are very grateful to his patience for allowing him this time out of consulting to be able to present this. I also want to thank you. I also want to thank Renee Ridley for the work that she's doing locally in our response to Japanese encephalitis, including providing vaccination clinics in our region, Japanese encephalitis virus being the topic for today's series. And also acknowledge Matt McConnell and the work that he's doing with CDCB in organising our response. We've had 5 confirmed cases and 3 probable cases in South Australia, including 1 probable death, all this year. And that compares to the previous history, as far as we know it, forever, of only ever having had previously 3 cases, all of which were overseas travellers returning to South Australia. So these between 5 and 8 cases of domestically acquired Japanese encephalitis virus represent a paradigm shift in the way we need to look at this particular virus and the way we need to organise our public health response. And I thank those people who are doing that. We felt this was an area that would be interesting, not only to learn about the virus and the public health response, but also as a stimulus to think about public health more generally. When we often focus on the patient in front of us in our health services, raising our eyes to look at the bigger picture can be very helpful, because we all know that that is often where the biggest gains are to be made. Dr. Felix Ogbo is a senior lecturer at Western Sydney University in public health, having obtained his PhD in public health medicine, and he is also training to be a general practitioner in our region. So we are very privileged to have Felix in our region, and we thank him for the work that he is already doing and the work that he will be doing in leading this series. And so, Felix, I hand it over to you to lead our seminar, take us through the papers and the other presentations that you have, so that you can lead our discussion of looking at Japanese encephalitis virus. Nori Andy.
Thank you, Paul. Thank you, everyone. We'll just try and share what I do have. There we go. So can everyone see what I'm sharing here?
Not yet, Felix.
No?
Perfect. Yes.
Okay. All right. So can you see that, Paul?
Yes, it's in presentation mode now.
All right. Okay. So thank everyone for your time, and thanks for joining us. Like Paul mentioned, my name is Felix. I work in Balmoral Clinic and also an RMO at the Riverland General Hospital as well, and trying to kickstart our public health unit in the early chain. So today I want to just give what I call a brief overview of what Japanese encephalitis is all about. These are some of the other names of Japanese encephalitis virus. Japanese B encephalitis, the arbovirus B, or the mosquito-borne encephalitis virus. By way of an outline, I will be looking at the introduction, the epidemiology, not just in Australia, but also globally, and how the virus is transmitted as well. My focus today would be on the virus in humans, because as we know, it also affects pigs, it also affects horses as well, and my focus will mainly be on humans. We'll talk a little bit about the prevention and control, and like Paul mentioned, thanks to Renee as well, I will just provide an update on the vaccination program in the early chain. So Japanese encephalitis virus, abbreviated as JEV, it is from the family of the flavivirus. It is related to the Murray Valley virus and the West Nile virus. The name is derived from a Latin name, flavus, meaning yellow. That also means that the virus is also a member of the family of the yellow fever virus, which has been around for a number of years. It is a single-stranded RNA virus. And by epidemiology, I want to just kind of provide a historical context. It is called Japanese encephalitis virus because back in the days, wherever an organism is discovered, then that place takes the name. In 1871, that was when it was first identified in Japan. And in 1924, there was a great epidemic in Japan as well at the time, with half of the people that were infected confirmed death. And in 1935, that was when the first virus was isolated from a fatal human encephalitis case. 3 years later, the virus was isolated from a mosquito, especially the Culex species. From 1940 to 1978, there was now a disease spread of the epidemic in Asia, including China, Korea, and India. So globally, there are about 24 countries in Asia and Pacific region that have the JEV virus or the transmission risk. And this region has over 3 billion people. Nearly 668,000 clinical cases of JEV are reported each year, and around 14,000 to 21,000 deaths annually. So that's quite huge, especially at the global level. The JEV virus primarily affects children, as most adults in endemic countries would have natural immunity after childhood infection. So this kind of provide that geographic distribution. Here we are in Australia, and this was done in 2018 by the WHO. You can see that, I guess, in 2023 or 2025, when the WHO looks at JEV again, they are going to bring down that they've now confirmed cases in South Australia, New South Wales, and Victoria. So this map is going to change in the next few years. So in Australia, the first case of JEV was detected in the outer Torres Strait. So if you look at up there in Australia, and in 1998, the first case was detected in Cape York Peninsula in 1998. Additional investigation on 450 sero-surveyed people were negative. So at the time, it was more like, oh, this was a mosquito-borne disease that was acquired overseas. So nothing was done about it at the time. However, things changed in 2022 when there were cases of the virus that were reported in Victoria, New South Wales, and somewhere in Queensland as well. And most of these cases were exposure that were close to the Murray River. In South Australia, there have been 6 detections of the virus in commercial piggeries. The detections are in local government noted, but specific to where we are, we have Loxton Wakery, the Murray Bridge, and the Coron. As of March 18, 2022, we have 8 confirmed cases and 1 probable death that was noted on the SA Health website. Transmission, how does the virus move from one place to the other? It is a vector-borne disease. It's transmitted, like I said earlier, by the mosquito. And the reservoir, which is the organism or the mammalian that hosts that virus, are many, but most especially the pigs, the waterbirds, bats, and also reptiles and amphibians. And the incidental hosts are humans, horses, and also additional household. So Japanese encephalitis, like I said, is caused and transmitted by the mosquitoes. This is the mosquitoes, and it feeds on pigs, and it comes back, another mosquito feeds on this pig, then of course that mosquito becomes infected. The key thing about the pigs and the waterbirds is that in the pigs, they do have sufficient viremia for the virus to grow within them. In humans, however, when the mosquito feeds on human, the viremia is not sufficient enough for the mosquito to pick that virus from human. Therefore, it is not possible for a human-to-human transmission to occur. Therefore, you cannot give the virus to the mosquito. So humans are often considered a dead-end host. That means once the virus goes into a human, it stays there and the period passes. But within the pigs and the waterbirds, the viremia is so high that when a mosquito feeds on the pigs or feeds on the waterbirds, they are able to also pick up the virus as well. In humans, only 1 in 20, 1 in 250 people will result in severe illness. So a large proportion, over 90% of people that will be infected with the virus will go on asymptomatic. without having issues. So like I said earlier, I want to focus on the infection in humans, acknowledging that we do have infection in pigs as well. So the incubation period is often between 5 and 15 days after being bitten by an infected mosquitoes. It goes through a number of stages. You have the encephalitic stage, which has 3 phases. The prodrome phase, which is around 1 to 6 days. It is difficult to distinguish the JEV infection from other viral illnesses. You do have the acute encephalitic stage, which is the most severe. They do present with headaches, high fever, stiff neck, stupor, and this may progress to paralysis, seizures, and coma or even death. There is the late convalescent stage, which is where those neurological, neuropsychiatric complications do come into effect, and the other stages are noted below as well. Like I said, over 90% of people would be in the non-encephalitic or the asymptomatic stage. So the neuropsychiatric sequelae can occur, and this can be permanent intellectual or behavioral or Parkinsonism features or inability to speak. And around 70%, 45 to 70% of survivors will experience these complications. There might be in utero infection. They've noted that it is possible, and that can lead to the abortion of the fetus. In children, like I said earlier, in Asia, most children are the ones that get the infection, and they would present with gastrointestinal pain, vomiting, and these are the dominant symptoms. The good thing from that is that natural infection infers lifelong immunity. So by way of diagnosis and treatment, the key in this presentation, I think, is to have that heightened suspicion in the context of appropriate clinical and epidemiological risk factors. We decided to kind of provide this update on JEV, myself and Paul, given that we're heading into the Easter long weekend, and there will be, of course, a number of people hoping to camp along the Murray River as well, given, of course, the abundance of mosquitoes. Then it would be very important for GPs, for emergency doctors to understand that a patient with both clinical and or epidemiological risk factors need to be detailed to ensure that we're not missing cases as well. And by way of diagnosis, you can either use the blood, you can use urine, you can use the CSF as well. And in many cases, just take the blood, and when ordering, just flavivirus PCR should be sufficient to provide some information as well. Unfortunately, there is no specific treatment for the virus, nor do we have any antiviral medication. All we have to do is to provide that supportive care. Mortality in pigs is quite high, especially in the piglets. It is rare in adult pigs. It is also rare in horses as well, but in humans, it can be up to 40%, and the serious neurological sequelae can be up to 70%, as mentioned earlier. In pigs, which is as part of the One Health approach to the virus, is looking at, you have the medical people and also the veterinary aspect that brings all of the One Health approach to the virus. In pigs, the most common clinical signs are the mummified or stillborn or weak piglet that are often noted. Postmortem lesions in brains, you have panencephalitis, and the thalamus is often the severely affected part of the brain. So prevention and control, I guess this is where it brings us not only from the clinics, it brings us into the community as well. And this is where I think much needs to be done. And the vector control is important, eliminating mosquito breeding areas, both adult and larval control, vaccination of pigs and horses, and for human as well. I'll talk a little bit about the human aspect. Personal protective measures, including avoiding prime mosquito hours, use of insect repellent, especially the DEET are also ways to ensure prevention as well. Vaccination. There are 2 vaccines that are available in Australia against the virus, the Emojiv and the Jespet. The first one is the live attenuated, and you only need 1 dose of that to be given. It can be given to people from the age of 9. However, it is contraindicated in pregnancy and women who do breastfeed, and also in immunocompromised people. The second one, you require 2 doses. It is inactivated, and you often will give it 28 days apart. It is useful for people who cannot have the live vaccine. The live attenuated vaccine is useful in reducing the incidence, especially when there is an outbreak. The protective immune response will occur for up to 14 to 28 days after vaccination. Most adults will still have protection against the virus after 5 years. However, it is unclear whether a booster is required after 5 years. So just to kind of highlight what Paul said earlier, thanks to Renee for providing us this information, what the LHN is doing in relation to the vaccination. There is ongoing collaboration between the RMC and the clinics as well, and each identify piggery or individuals identified as high risk. There are booking clinics at Murray Bridge or Berry, which is at the Riverland Central Plaza. So far, from the LHN, 105 people have been vaccinated, and that will be 108, and there is enough supply of the vaccine to go around. I think 3 weeks ago as well, personally, I vaccinated around 8 or 10 people from a particular piggery as well, and of course, this is going on within the clinic in the region. References, and if there are any questions, just let me know.
So, Felix, thank you very much for that. And thank you in particular for providing 3 of those references, the 3 articles. The original article that was the first one to describe Japanese encephalitis in Australia back in 1995. An update on that, which basically said in 2019, well, we've sort of forgotten about it because we don't think it's an issue anymore in Australia, and then an article which I guess showed the main way that we viewed it, which was as a disease that occurred when people came back from overseas. And there was a case study that described in detail the method of typing the virus, and unfortunately I found it as one of those rather grotesque articles that spends a whole lot of time talking about this patient, and then in one sentence says, oh, and the patient died. I find those articles quite sometimes disrespectful in the way they seem to be so interested in the way that a person can die. But I'm interested in looking at those, looking at the articles and just listening to your presentation. I'm interested. Why do you think there is so little attention being paid to treatments for a disease that kills over 20,000 people every year? Why is that? Why is that the case, do you think?
A number of things, I guess. Kind of don't want to go to global health. I want to just focus on I guess the Japanese virus. I guess it is, in my view, due to a number of things. One, there is that lifelong immunity if one has it, and in many cases, people have talked about the globalization of things, especially in this case, because there is no, I guess, developed country issue to it that can, in my view, something that can be a factor. in the US, there hasn't been a case of Japanese encephalitis, and the Americans wouldn't be saying anything about it because if it does not affect them, then they won't do anything about it. Even looking at the Australian example as well, in 1998, they said this is just for people coming from overseas. But now people are saying it likely due to the floods, also likely due to climate change as well, that is bringing in all of those mosquitoes across. And whether that is true or not, it is something that people would investigate. So I guess it is one of those diseases that people have said this is for developing nations. Then there is a lot of funding, a lot of research into it. And I guess it is when, in my view, this affects richer countries, then there will be more money into treatment and into vaccines as well. That is my view. I'm not sure, but given other aspect of diseases in the global health arena, that would be how I would view it.
Thanks, Felix. I'm interested in other people's views on that, or other questions that that people may want to raise. So it's over to the seminar for questions or comments. I see there was one question in the chat. See if you can write. We'll have opportunity to actually speak the questions, but there was a question in the chat, and don't know if you want to have a go at answering this, Felix.
Yes. So the question is, will the threat lessen? Will the threat reduce in colder temperatures, especially given that we're heading into winter? It is possible because the virus thrives in temperate region. That was why in Japan, when it first occurred, they called it the summer encephalitis. So it is something that is possible. And even in the WHO website, they said it is commoner, or is most common in countries with temperate or tropical weather. So whether that would reduce it, I guess it is possible given the evidence that we have at this stage.
Thanks for that. Maggie, you've got a question or a comment.
Yeah, my question is about, you mentioned about the vaccine being available and that it's being offered to people who are in a high risk category. What classifies being in the high risk?
So I guess it's people who worked in the piggery, the family members. I guess that is the information I got from based on the SA Health information. So there are people considered at high risk, and that is something that Renee works through in ensuring that they get the vaccine.
Is there any thought, you mentioned as well, because children with under 5 are higher risk, is that a thought that they might be able to access the vaccine at any point?
Yes, I think at this stage, you're basing it on the criteria as to if you work in a piggery. So if there is a child that it is in a household where there's someone with it or works with piggery, then yes, they would be eligible for the vaccination. But on a blanket rule in the community at this stage, no.
Yeah, it's a good question, Maggie, because it gets to that heart of if there's a limited resource, and there is a limited resource of vaccine available for this in the country, how do we prioritize that in a way that is both fair and also presumably, hopefully, will reduce the chances of the whole population becoming infected. And Felix is quite right. The current approach is that the predominant risk is in people who are close to pigs, because they are the domestic reservoir for this. A case could equally be made of people who are close to waterbirds, because waterbirds are another reservoir. They get a viremia that's sufficient to be able to infect another mosquito and therefore perpetuate the virus. But I don't, at this stage, see it being made available to people who go camping next to the river in our region, and I think that's just a factor of how many vaccines we have. Is that your view, Felix, as well?
Yes, and even in Asia as well, from what I read, they still kind of prioritize who they vaccinate as well. And vaccination have reduced mortality, and it is the key to kind of reducing the burden of the virus globally.
Of course, one of the other ways that you can reduce the virus is by not getting bitten. Or by reducing the number of the particular mosquito that carries the virus. There's been a lot of work done in malaria around prevention of getting bitten. Again, because there's been a sort of a lack of very effective treatments for that. What would your advice be to people around how to prevent actually coming in contact with this virus?
So there is a lot of information now, given the onset of the virus a few weeks ago. Around, there's this campaign, Beat the Bite, that has been there for years now. And in that document, they talked about currently we were dealing with Ross River virus, the Murray Valley virus, encephalitis. But in the future, we might deal with Japanese encephalitis virus. So now we're not dealing with the virus. So the right number of things to do, especially to ensure that we're not beating. Of course, you can't prevent people from camping. It is a good thing to camp. But if you want to do that, wearing long sleeve, the use of insect repellent, ensuring that there are no water reservoir around where you are camping or in your homes. These are measures that have been shown to be effective in preventing not only mosquito that carries the malaria organism, but also for other viruses, including the Japanese encephalitis virus.
Have you seen repellent impregnated mosquito nets going up for sale? I know that's something I certainly used when I was working in the Philippines. That was just accepted, that you would always go to sleep under a net, and you would spray the net to make sure there were no mozzies that had got in before you did. They were just hiding there, waiting to have a feed overnight. Have you seen much of that occurring, or has anybody heard of those being available at Bunnings or Mitre 10 or Snowies?
I guess people have made careers out of prevention of malaria, and kind of bringing that into the prevention of the Japanese encephalitis would be good. I think we called them back then in Africa, the insecticide-treated bed nets, and I used that back in Africa as well, and did research as a medical student. And when I graduated, they are effective in many cases when you have a large proportion of people using them. So if I buy single net and I'm using it, whether or not it's going to repel all of the mosquitoes around me, anecdotally, I'm not sure. But the evidence, it's in the community where you have a large proportion of people using them. However, there are problems with them as well. going back to Africa as well, where the temperature is the weather is quite hot, and asking an adult to sleep under a net when there is no electricity, people would say, no, I can't sleep because the weather is too hot. I'm not going to sleep under a net. There are a lot of issues with it as well. But having said that, if you're going on camping and sleeping under a net to avoid the mosquito, I'm not sure how one will sleep under a net in a camp, because you're already sleeping in a small and a closed space. So it's something that would be difficult as well. Having said that, wearing long sleeve, the insect repellent, there are a whole range of insect repellent out there. So I guess just using what you think that is comfortable would be good.
Thanks, Felix. Other questions or comments from people about Japanese encephalitis and the response that we're having here in Australia? Felix, a question that often comes up with public health issues is there a demographic gradient when it comes to mosquito-borne virus illness, like Japanese encephalitis? In other words, is this a disease and an approach that seems to affect the poorer segments of society more than the richer segments of society? Do you know if there's what the evidence is around that, and what can be done about that?
I have not looked at whether it affects a particular social demographic, but given the epidemiology, one would expect that it does cut across every demographic. However, it is more severe when it affects children and the elderly. So, like I said, it's in the prodrome phase. The symptoms are similar. It's very difficult to differentiate the symptoms of the Japanese encephalitis from that of the everyday flu or other viruses. So it's quite challenging to kind of note that. However, it is more severe in children and in the elderly. But the epidemiology is quite clear for those who work outdoors, who works with pigs, works in waterbeds. Then you would have expect that these are the people that you would expect a high incidence of the virus.
Okay, that's really helpful. So I'm just looking on the people to see if there are any other questions or comments from people. I'm just having a look in the chat, and can't see any other questions in the chat at the moment. So if there are no other questions or comments, it remains to me to say thank you, Felix, for that presentation, that update for us. I think this is really important that we are well informed, because as members of a health service, we will be asked on a regular basis, what is this Japanese encephalitis? Am I at risk? How can I decrease my risk? And it's important that the responses we're able to give are informed by the best evidence. And I think what we've heard today is the best evidence that we have. So thank you for that, and thank you everyone for attending. This presentation will be available on our social media sites, so that it can be viewed later. So if you have other colleagues who would like to know more about this and hear our presentation, then you can send them to our YouTube site and they can view this presentation.